An approach to patients with weakness.
A 56-year-old active man presents with 1 week of difficulty moving his legs. He states that when he tries to take a step forward, his legs want to collapse. He describes mild numbness and tingling in both legs, but he does not have any pain. He has no other neurological symptoms or bowel or bladder dysfunction. He is not on any steroid or statin therapy. What additional elements on the history and physical examination would be most important in creating a differential diagnosis?
Although evaluating a patient with weakness may seem daunting, understanding how to assess different possible causes will help focus the evaluation and narrow the differential diagnosis. Here, we will discuss key symptoms and physical exam findings that are crucial for this categorization.
A detailed history is critical for classifying weakness correctly and entails three key components: localization, timing, and associated symptoms. Localization: is the weakness generalized or focal, symmetrical or asymmetrical? Does it affect the lower extremities or the upper extremities? Is there involvement of proximal muscles, distal muscles, or facial muscles? Timing: acute onset suggests etiologies such as a stroke, postictal weakness, demyelinating lesions, or a traumatic event. Inflammatory, neoplastic, and toxic or metabolic causes can present within subacute onset. Progressive worsening over time is seen in neurodegenerative disorders. Fluctuating course of symptoms suggests disorders of neuromuscular junctions. Associated symptoms can help to further elucidate casual etiologies. Isolated weakness suggests a problem involving motor neurons, neuromuscular junction, or muscle, while disorders affecting other parts of neuroaxis may have symptoms of sensory, autonomic, brainstem, or cortical dysfunction.
A general medical and neurological exam should be performed. Exam findings can help characterize weakness into one of 5 anatomical locations: brain, spinal cord, lower motor neuron and peripheral nerve, neuromuscular junction, and muscle. Be sure to assess for upper and lower motor neuron signs. Upper motor neuron problems typically have spasticity, hyperreflexia, pathologic reflexes, and no muscle atrophy. Lower motor neuron problems have flaccid tone, hyporeflexia, muscle atrophy, and fasciculations. For disorders affecting the brain, upper motor neuron and cortical signs are common and are often unilateral. Spinal cord processes are suggested by upper motor neuron signs and a sensory deficit below a specific dermatome level. Bilateral extremity weakness and bowel or bladder dysfunction can be present. Lower motor neuron, peripheral nerve, nerve root, and plexus disorders often have lower motor neuron signs and may have sensory deficits. Neuromuscular junction disorders are characterized by weakness that worsens with muscle use and fluctuates during the day. There are no sensory deficits, and reflexes are often preserved or decreased. Myopathies typically cause fixed weakness that affects proximal muscles more than distal, decreased reflexes, and lack sensory deficits in upper motor neuron signs.
Our patient's history reveals he had diarrhea 2 weeks prior to his symptoms, and his weakness and numbness gradually progressed up his legs. Physical exam showed symmetrically diminished strength and absent reflexes in the lower extremities with reduced pinprick sensation. This combination of lower motor neuron signs and sensory deficits is most consistent with a peripheral nerve disorder. The subacute time course makes an infectious, toxic metabolic, or inflammatory process more likely. The patient was admitted to the hospital, diagnosed with Guillain-Barré syndrome, and treated with IVIG.
To learn more about this and other neurologic conditions, please visit aan.com/neurobites.